All right. Well, we are live. Thank you guys so much for joining our webinar today. My name is October Boyles. I'm the Chief Clinical Officer and Customer Officer with Notes, who is the host of today's webinar. And I really, really appreciate you guys for joining. We have a lot of folks in here so far, and that is wonderful. I also want to introduce Monique Ornelas. She is a behavioral health emergency department nurse practitioner. She has over 15 years of experience in her field. She's worked in inpatient and also mainly in the emergency department. And so she has had a wealth of experience in dealing with crisis, and I think is a really fabulous speaker. So Monique, thank you so much for joining us today.
Thank you for having me.
So we have a lot of folks in. It's so good to see you. It looks like that right now, so we had over 1,300 people registered for this webinar. Over 1,300 people. So we do expect a lot of folks to be in today. And I see a lot of you are joining. So I do have some people saying that there's no sound. So I want to make sure that everybody gets their sound. If you're not hearing any sound, do me a favor, log out of the webinar, log back in, and there's a little button up top that says click for audio. But for some folks, it's in the middle of your screen and it may not be too obvious. So just go ahead and log out and log back in and click on that. Good afternoon, Christina. Good to hear you. Good to see you. Hello, Kelly. Nice to see you in here. Fantastic. We've got a lot of folks that are joining in now. So I'd like to do my webinars when I'd like to figure out where people are from and what their discipline is, because I like to tailor the webinar to the folks that are in the webinar. So if you wouldn't mind sharing your name, tell me, your name's already on there, so don't worry about that part. But if you put your discipline and then also where you're located at. Love to see where people are located at. Catherine, hello. John, Anna, Robert, Olivia, great to have you in here. Yvonne, Fato, I hope I'm saying that right. Fato, Sunny, Amy, Judith, Tammy. So we have a lot of folks in here from Baltimore. That's fantastic. That's where Notes is located at. We are out and we're born and created in Baltimore, really the Annapolis area. So we have folks from Oklahoma, Alabama.
Wow.
Las Vegas. Fantastic. Yvonne, Las Vegas. We love Vegas. We love Vegas. Maryland. That's great. Virginia. A lot of Maryland. Georgia. Melissa, you are my neighbor. I'm located in North Carolina, Charlotte, North Carolina. And so is Monique from North Carolina as well. But she is from Tennessee. So it looks like we have some folks from Tennessee in here. New York, New Jersey. So addictions counselor, Catherine, lovely to have you in here. Fantastic. Social worker, Montreal. All right. Fantastic. Kansas, Florida, New York, mobile crisis response. Fantastic to have you in here. Crisis service director, Iowa. Excellent. Christy, thank you so much for joining us. Broward County and one of the offices in Tampa. Tampa is one of my favorite places. And you know what? I'm really jealous because it's very warm there right now. Right? So I know a lot of the other folks in the webinar are jealous as well. Mona, North Carolina, great to have you in here. Vancouver, fantastic. We have some students in here. It's wonderful to see you guys in here. Iowa, Arizona, also a very nice temperature related place right now. A lot of folks from Canada. Thank you so much for joining us today. Dakota, Dallas, New Jersey. Wow. Thank you guys so much for joining. We have a lot of folks in today, and it's so good to have you in here. Well, I'm going to go ahead and get started. But thank you so much to Kelly, Robert, Allison, George, everybody, Camille, Andrea. Thank you for joining. And what we're going to be talking about today is something that unfortunately has kind of ticked up in the past couple of years, and that's basically crisis. And our daily lives sometimes feel like it's a little overshadowed by crises, right? There's always conflicts going on. There is war going on. There's the kind of the looming war that could be happening. There's political scandals, there's deep societal divides. And in the midst of all of this turmoil, it's really easy to become overwhelmed and disheartened and feeling as though the world is constantly in a state of chaos. And despite this tumultuous landscape, it's really important to acknowledge the depth of emotions that arise for individuals, the anxiety, the fear, the frustration, all of that can accompany crises that are real and that are very valid, that people feel that weigh heavily on them. And not only does it weigh heavily on individuals, but also on communities. And this is a time where we can empathize and really understand with individuals and recognize the power within each one of us here to make a difference within our patients' and clients' lives. And obviously, kudos to everyone in here because you're coming in here today. A lot of you already work in crisis areas, and you're in here today kind of learning more about how different techniques or skills in your area. So a huge kudos to you for being in here today. Thank you so much for taking your time, because time is something we don't all have a lot of, right? And so I really, really appreciate you being in here. I do want to go ahead and give a trigger warning right before we get in. Some of the things that we are going to be talking about could be triggering to individuals. I did see some things that I did see some folks that have private messaged me that are not clinicians in here. And it is okay if you want to stay in. That's not a problem if you want to stay into the discussion at all today. But I do want to go ahead and give that trigger warning. Okay. So, all right. And Steve, I will get started. I promise you. So, learning objectives. So basically we're going to be doing today is we're going to define the concept of a mental health crisis. We're going to talk about identifying indicators and manifestations that really suggest when an individual is going through a mental health crisis. We're going to talk about comprehensive risk assessments and which ones we feel like are the best, and not we feel, but evidence-based, and crisis de-escalation techniques. We're going to talk about robust safety plans, and we're going to talk about appropriate circumstances, really making it referrals necessary to other mental health professionals. And that's why Monique is in here as well, to kind of help talk about that as well. So thank you so much, Monique, for joining. Got some more folks in. Fantastic to have you in, Kim and Sierra. All right. So these are some disclaimers for safety considerations. And if you see me looking to my left, that's where my slide deck is. So, but these safety disclaimers we're going to go over. And I have a question to folks in here. The states that you're in, and we have a nice diverse amount of states in here. The question is, in your state, can anyone involuntarily commit someone, or must you be a clinician? Because I'll tell you, in the state of North Carolina, anyone can involuntarily commit folks in the state of North Carolina. And so that's one of the things that is, I'd like to know in your state, and you could put your state, yes or no, can anyone involuntarily commit any? So Mona says anyone. Patricia, you must be a clinician in Maryland. Yes. All right. Absolutely. So what we're talking about with the disclaimer for safety considerations is we're going to give you some insights today, but they're not intended for the end all be all. Okay. So I think it's really important to know that all clinicians do different things in different areas. I will give you an example. There was a study where there was 18 psychologists and social workers, and they all did the risk assessment questionnaire, and they did it for 169 patients or clients. And all of those clients that they did it on had some degree of risk, and 42 of the patients were admitted or involuntarily committed. And when they did this study, they wanted to find out why these 42, because out of 169, they all scored the same amount of risk. And what they determined was it was decision-making factors that really influence, like the setting, the clinician's tendency to involuntarily commit. And also what was interesting in that study was the availability of beds in the area really determined why people would admit. And so some of the things that we're going to talk about today, you might say, well, I don't necessarily agree with that. If the patient was at this risk, maybe I wouldn't admit them. And that's okay, because we're all different. And your patient. We've got a lot of responses in the chat. So here in MD must be a clinician, Washington State, no, Colorado, no, Massachusetts, no, must be a clinician or medical doctor or police officer in Florida. Indiana must be a clinician, New Jersey, mental health screener. So a lot of great, okay, fantastic. A lot of great comments there. And I think it's really interesting to learn about other states. The 5150, the hold is not the same as the actual commitment. So great. Thank you guys for sharing that. I love learning about different states and laws, and they are so much different. Now, when we talk about suicide facts, because when we talk about crisis, I do want to talk about suicide because the most important thing we do is keep our patients and clients safe, right? And so I will tell you that the suicide rate among U.S. the working population has increased 33% in the past 2 decades. And we have some CDC numbers that just came out in December of 2023 that were different than something that I had always heard or anticipated. So one of the major groups that when you think about groups or professions that commit suicide, what's the first profession that kind of comes to your mind? And I'll tell you, I had always heard dentist. I don't know if you guys had heard that. Monique is shaking her head. So this was not something that I just made up, right? I've always heard dentist. I heard healthcare, folks that work in healthcare. And that makes sense because their jobs are highly stressful. But what the new study showed, and this is a study from the CDC, they did it in 2021. Results did not come out until like just a month and a half ago. But the major occupational groups with the highest suicide rates were construction, and also farming, fishing, and forestry. So construction and agriculture. And then underneath those professions was personal care services. So I found that to be really interesting because it changed perspective of kind of what I had always been told. Now, another thing that I want to talk about is it's important to know the groups of individuals that are at risk for suicide, but also the way that people commit suicide. And so when we're talking about suicide, what do you feel like? I'd love to hear this from the chat. What do you feel like the number one way is that individuals commit suicide? And I love the responses in the chat. Thank you so much, Kathy, Vanessa, Carol, Lauren, Molly, Tara, Janina. Thank you. Yeah, right there. Everybody, see, Christina, I thought the same thing. Frontline workers, attorneys, yes. Police, absolutely. That's exactly kind of what I've thought. So I found those statistics a little bit shocking. Again, it's from the CDC. It's a reliable source, and so I wanted to share those. So a lot of people, yes. Christy saying guns, Kathy pills, Catherine gunshot, hanging, gunshot, OD, pills, guns, shooting, meds, pills. Yes, we have. Well, and you guys are right on it. When I talk about suicide facts, in 2021, 54% of all gun-related deaths in the U.S. were suicide, while 43% of gun-related deaths were murder. So, and then the other, if you're like, well, 43 and 54, that doesn't add up to 100%. Some of them were accidental. Some of them were involving law enforcement, and some of them were actually when people were working on guns. So but 54%. So, and that is then next, because a lot of you were right on it as well, 54% of men and 30% of women die by suicide of firearms. 28% of men and 28% of women were on hanging. So it used to be that we thought that men actually hung themselves more than women. That's actually not true from that statistic. And 9% of men OD and 31% of women. So some statistical data that were a little bit different than what I had always been told. So, and they're not a lot of, there are not a lot of laws around this, and I'm definitely not getting into political discussion about guns. But I will tell you that among Americans that are 10 to 24, suicide is now the second leading cause of premature death, which is terrifying to me because I have a 9-year-old that's about to be 10 and I have a 13-year-old. So meaning of the age group of my sons, that suicide is the second leading cause of death. And that's why talking about suicide, talking about crisis is so important. And especially, and Monique, in our conversation, we had a conversation yesterday. You were saying you were seeing a lot of child and adolescents come into the emergency department. And the number is about 42% of high school students report experiencing persistent feelings of sadness or hopelessness. And that is up 41% in the past 20 years. So a lot going on. We have definitions of a crisis, have them from two leading organizations on definitions of a crisis. And I think that it really speaks to kind of what a crisis is, but I want us to talk about what a crisis is. And here's the reason why. Right now, we have well over 300 people that are in this webinar right now. And most of you have a lot of good mental health experience. So instead of me doing the talking, I like to get feedback from you. I love participation. So we're going to talk about what a crisis looks like. And I want you to tell me, this is what textbook crisis looks like, the slides that I have coming up. But I want you to tell me what a crisis looks like to you. Like, what have you seen with your patients? I'd love the chat to get engaged with that. Like, what are some things, crises, when a person is in crisis, what are some things that you have seen that are not textbook or even that are textbook? If you think about a current or past patient of yours that was in crisis, what were some of the things that you saw? And Monique, do you mind sharing? Because you see folks, you're really they're coming in, it's a behavioral health emergency freestanding department. You don't see folks with medical issues. It's only folks with behavioral health issues that are generally, or sometimes are in crisis. But can you tell me a little bit about that when they come in your ER, what that looks like?
Sure. So oftentimes folks are brought in by, different resources in the community. It could be social workers, their therapists, it could be family members, police officers, etc. So sometimes when they arrive, they may be very acutely agitated, yelling, cursing, unable to accept any kind of redirection. Others might just be crying uncontrollably. Others, may be able to hold it together a bit more. And their family who's with them may be more distraught looking than they are, as their family is quite concerned about their loved ones being in that crisis. But yeah, so definitely lots of acute behavioral changes, as you've mentioned here in your list.
Crisis can look different for different individuals. And there's a lot of great comments in the chat as well. Like, it could be late bills. Talissa said late bills, family issues, uninvolved parents, bullying, experience after a relapse of years of sobriety. That's very true. Catherine, thank you so much for sharing that. Larry said just broke up with a spouse. John says nowhere to go, no escape route at all. And absolutely. Norma, I think you brought up something, being unable to provide for the children, a removal of children by DCS. Yes, absolutely. Really fantastic things in the chat. Catherine said an incarcerated individual getting bad news from a judge. Absolutely. Crisis, right? Absolutely crisis. Overwhelmed, disruption in life. A lot of things in here about financial issues. Adele and Patricia, like financial issues. A loss of home, racial trauma. Nicholas says racial trauma and inability to manage emotions. Somebody in the chat said terminal, like a terminal illness, getting that. So Elise says gender dysphoria. We actually have a webinar coming up on that in 2 weeks on gender dysphoria. So we have a whole panel of participants. So that's going to be really exciting. I believe that's on the 29th. Kathy said repeated domestic abuse. Absolutely. Absolutely. Christina said veterans unable to get appointments in a timely manner. This is a lot of these things. Absolutely. And I'm sure, Monique, you see in your day-to-day, you see lots of these issues coming in and people in crisis.
And sometimes there may not be a trigger.
But absolutely. That's true.
Sometimes those are just overwhelmed and things may have been building up, and then they enter into a crisis. And
yes. Very true. Very true. A buildup is huge. Chantel said losing a job. I have seen that. I'm very active on LinkedIn. So feel free to go on LinkedIn and let's connect if you're in here. But I have seen a lot of job loss going on. So Chantel says losing a job, grief with trauma, experiencing racism. Jacqueline says, and Thomas says impacts from coming out or being outed as an LGBT person. Absolutely. Nora says relationship breakup. While I was working in inpatient, that was a lot. I saw a lot of relationships. People would come in admitted due to relationships. AJ, perfect. Medication noncompliance. That can absolutely be a crisis. So
a lot of what I'm seeing too is with adolescents and children. They're, being limited or having consequences for their behaviors. And so they in turn have an acute angry outburst that results in a crisis. Oftentimes cell phones, oh my gosh, anything with a cell phone. Children, adolescents, they're getting their cell phones taken away, or if they've been accessing things inappropriately on social media, they're being bullied by folks on social media.
Yes, absolutely. Amber said total lack of supervision at home, which leads to behavioral issues at school. I think that's really important. Chelsea, thank you for sharing that experience. Yes, it's a lot. Now, I want to just move back over. Sorry, I keep losing my slide deck. So let me slide that back over. I apologize here. These are some risks of crisis that, and of course, at the very top of the list, we have the risk of suicide. We have the risk of homicide, of self-harming behavior, extreme. What are some things, Monique, that you have seen that are maybe not on this list, or things that you see that like the most common? And to the audience as well, what are some things that you have seen that maybe are not on this list?
Sure. Well, to be clear, most folks that come to see me are coming in voluntarily. So either they've had a family member or someone that's close with them who has encouraged them to come get some care, or they've been able to locate us on their own research. So they're trying to prevent risks, hopefully, of what this crisis could cause. So I'm thinking loss of employment, further interpersonal conflict with their loved ones or with their family members, colleagues at work, academic impairment or dysfunction, their perhaps substance abuse, risking a relapse. Sometimes if they're acutely paranoid or having a psychotic break, that could result in disruption in the community. So having police involvement or, losing some trust within their communities amongst their neighbors and things like that, the stigma that could be associated with that. Parents who, might be in crisis may not be able to provide appropriate care for their children. There's just lots of things that could go awry if we do not address the crisis when we're in it.
Mm-hmm. Absolutely. Kim said something about that. She kind of touched on exactly what you were saying too. Child abuse and domestic violence are definitely crisis risks as well. And a lot of great comments here. Having no resources to help fill, psychotropic medications. Excellent. Christy, Kevin, disillusions with life and confused. John said job loss. That's not knowing when they're going to pay bills. So I'm seeing a lot of things about financial on here, and that is in the forefront, right? That is definitely in the forefront. Non-compliant with medications. Monique, I love this, Monique. Thank you for sharing. Trafficking victim returning to independence. Absolutely. Now, I want to talk about, and this is a little bit about what we've already seen that can potentiate a crisis. There are a lot of traumatic events, witnessing a traumatic event, abuse, and you guys have said it exactly in the chat. Monique, you said it as well. Assault, natural disasters, custody issues. Kate said custody issues. Absolutely. Carol, bipolar disorder. Yep. I really like the perspective Larry said, caregivers not knowing how to handle behavior on a person that has dementia or Alzheimer's. Absolutely, that can precipitate a crisis, a mental health crisis. And you touched on the chat was amazing as far as financial difficulties, relationship problems, work-related issues. And so we definitely see a lot of that with a crisis. So now I want to go into, let's talk about kind of how to treat and help during a crisis. I want to kind of switch gears. And this is one of my favorite assessments. It is made in 114 languages, is out there, the Columbia Suicide Severity Rating Scale. There are multiple versions of this scale. So the one you're seeing here is kind of triage points for primary care. You have the recent, last visit. We have really comprehensive assessments. And the CSSRS is fantastic in the fact that it doesn't take clinicians a lot of time to do. Okay, it does not take folks a lot of time to do, maybe 2 to 3 minutes. But there are some important factors that you need to follow with the Columbia Suicide Severity Rating Scale. There's also longer versions, like the Safety T version. And we have handouts in here for you. And I want to make sure we get, if we haven't got that in there, I'm going to get these handouts for you. One, the scale for mental health professionals to be used in there, which really the CSSRS can be given by anyone. But also there's a Safety T, which is a little bit longer, but might be good for folks that the first time you've seen them using that Safety T scale. Thomas said the Columbia scale has an app too that you can get on your phone. I absolutely love that. So fantastic. Monique, can you talk about your experience with using this scale? Because is this scale used in the behavioral health emergency department?
Yes. So every person that comes in and is triaged by our nursing staff receives the CSSRS. Oftentimes, if someone's been referred by their school or their therapist, they typically also have they have completed a CSSRS amongst them. I think the key is that these questions need to be asked verbatim versus, more generalized. For example, have you ever thought about hurting yourself? That is not in the CSSRS. So I always encourage folks to ask the questions word for word as they are listed on this assessment tool. Otherwise, it makes it invalid.
That's a really good point. That is a really good point. A lot of time went into getting the verbiage exactly correct on that tool, right? There are a lot of big schools involved. I think Columbia was obviously involved. I think there was other schools there as well. So I agree with you 100%. So on that, I want to talk a little bit, and there are a lot of good tools out there. Matter of fact, at ICANOTES, we did several months ago, we did a behavioral health assessment tools that you can use for depression, anxiety, for bipolar, for OCD. And we took a whole list of forms that were open domain forms, because what's happening right now is so many forms, and this is not the case with the Columbia Suicide Severity Assessment. Anyone can use this. You do not have to pay for it. But a lot of psych assessments out there, what are happening are these companies are coming in and they're buying these older, very valid, evidence-based forms, and they are copywriting them so that you must use them in electronic form, and you must pay as you go when you use the forms, or you have to pay a large fee for the forms. And so ICANOTES, because I don't really think that's a great thing to do. The people that created these tools did back then, and some of these are older assessments, did not intend for them to be charged for. And so some of their original creators have passed away. And so these companies have kind of come in and bought them. So what we did is we created a list of all, and there's quite a few on that list. I think it's like 75, could be even a little bit more. And so if you want that, we can put a link to that in the chat so you can see that tool, that all the open domain forms. All right, so I'm going to move on to de-escalation, and this is the kind of the textbook meaning of de-escalation, and we're going to talk about de-escalation. I'm getting a lot of yeses in the chat, so absolutely. Can someone from our team share that list in the chat?
Yes, we'll do that.
Thank you so much. All right, now moving on next, we're going to talk about de-escalation skills, and I think these are the four most important de-escalation skills. They're obviously, and we'll go through each one of these. And the first one is going to be nonverbal communication. And I think one of the things that's really important is when someone is in a crisis to try to remain calm, because anxiety breeds anxiety, right? So we try to maintain being calm, monitor your facial expressions. I think that's really important. Be careful of your body language. Practicing mirroring behavior is okay. Also respecting personal boundaries. When working in inpatient, and I know Monique in the emergency department, you keep a safe distance between yourself and the person, because they are in crisis, and sometimes they will then put individuals around them in crisis. And that's one thing we're going to talk about as well, is just being in crisis. You want to make sure that you're safe at all times. That's very, very important. What are some things that you folks in the chat, and thank you so much for your participation. I absolutely love it. Y'all are amazing. But talk to me about some of the things, Monique, that you see on this list that you think are really important. And then also in the chat, if there's something as far as nonverbal communication that you feel is also important, please put that in the chat.
So I would say, for folks that may not know, I work in the self-standing emergency department. That's for behavioral health. When folks first come in, they are immediately greeted by our registrar staff, who is just kind of getting a general idea why they're there. And our security staff is going to go ahead and put them through the metal detector to make sure there aren't any kind of weapons or anything like that. So initially, of course, we've provided a very comfortable space for folks to enter, ease of access. So we're available 24/7. So again, that kind of hopefully creates that comfort for folks to be able to come and access that service when they need it. During triage, of course, the nursing is trying to assess for that immediate crisis, whether they are safe in the outer lobby where they may not need to be, locked or completely monitored by other staff, versus going to our secure lobby where they would need more observation, and just to make sure that they don't hurt themselves or anyone else. So again, they're interacting with our psychiatric technicians, who are, asking them how they're doing, interacting with them in a calm manner, trying to gather information, but also making sure we respect their space and, the reason why they came to come see us.
That's fantastic. That is wonderful. We also have some really good comments in the chat as far as eye contact. Hattie says eye contact. Patricia says all of them are good as far as nonverbal. Open body language. John said body language is very crucial. Megan says eye contact and engagement, especially in telehealth sessions. I think that's really important. You're absolutely right. Kim says practice breathing. And while they're in crisis, Jasmine says remain calm, and eye contact, mirroring, awareness are good. Absolutely. Robin says body language, eye contact. And Brenda says non-defensive body language. I like that. Nicole, you brought up an important point, using silence at times. Using silence, being able to use silence. So very good. All great. All wonderful. And thank you so much, Amy. Thank you. Paraverbal communication, I think, is really important as well. It's paramount, and because the tone of your voice really sets the emotional context of the interaction with the individual. And I think that if you adjust the pitch of your voice, that can convey sincerity and understanding. But you can say the same thing, but say it in a different tone and pitch, and it means completely opposite things. And I know you all have been in these situations where someone says something to you that the words themselves aren't necessarily rude, but the way that they said it and their tone can be very rude. And so that's why controlling your voice in communication is really, really important, because you want to remain respectful and non-threatening. And that you might actually, your voice can actually determine whether the escalation of the crisis continues or they de-escalate. So another thing is adapting the pace of your speech to match the individual's emotional state, I think is really, really important. And so, and I've seen, Monique, I've actually heard you in practice talking to people, and when they're escalated, I feel like you drop your tone and you get quieter. Is that?
Well, and I think something else that helps is sometimes folks might be triggered by certain individuals, maybe their gender or their race, or maybe just the way that person is interacting with them. And I don't know, I'm in a different color of scrubs at where I work. The providers, we wear a different color than other staff. So I feel like my immediate presence, if I hear something, for example, that's starting to occur, a crisis that's happening, just sometimes going out there and, asking staff to step back and ask the patient, one-on-one, tell me what's going on, how can I help? Just someone who's kind of coming in. I don't know if it's necessarily because they know that I'm the provider versus a member of our staff, or again, it's somebody's different tone. Maybe I'm not as defensive because I know my staff is going to keep me safe. So going out there and just kind of, again, but yes, my tone is very important. The way that I approach, if I came out yelling, for example, that certainly would not be helpful to them or my staff. And that would actually probably put my staff at risk for getting hurt as well.
Absolutely.
So we always want to use those tools to hopefully decrease our risk of having to put them in any kind of physical restraint.
Absolutely. Absolutely. I want to, there are a lot of fantastic comments. I want to point out this one from Lorraine. Lorraine says, environmental awareness as people watching the situation may affect the client. That is so true. Because a lot of times if you can remove the audience, that helps the client de-escalate. Whereas if there's a lot of people, sometimes that just completely escalates the situation. So really, that absolutely. Wanted to talk about a little active listening. I think active listening is so important. Not interrupting, not disrupting their flow of thoughts and feelings. You talked a lot about yesterday when we were talking about Nick, you talked a lot about validating people and empathizing with them. And I know I like to use clarifying questions. That's one of the things. But what are out of this list? What do you see anything that's not on the list or?
Well, so I guess so now we're kind of more in the phase where the person is in a safe environment where they're kind of being open to talk about how we can assess them getting out of their current crisis, I'm assuming. So active listening, of course, isn't going to necessarily work with someone who's acutely psychotic or agitated. So what I guess, again, they've probably already seen my nursing staff. Maybe they've met with a social worker. So they've kind of been able to tell a little bit more about why they're there in the setting, what kind of led them to have a crisis. And so I'm coming in to assess whether or not we need to pursue outpatient resources for this person, or if we do need to proceed more with an admission or observation stay. So I think in that discussion with them, talking about their ability to cope with whatever is happening around them, are they able to engage with me to let me know what types of coping mechanisms they may typically utilize? Are they going to be able to give me more information about how we can problem solve, perhaps something more specific that might be leading to this crisis that has brought them there? And if they're logical and rational, there's lots of different coping mechanisms that I like to make sure that we're kind of working on together.
Mm-hmm. Absolutely. Absolutely. And I think that, well, one thing, and I do want to go back to kind of in the listening, and you said something about, they said something that was really important. So I want to come back to that, but I also want to recognize in the chat, Jermel said, often seeking the staff member who has the best rapport with the client is most effective during the crisis. I cannot agree with that 100%. And then Chelsea, I love this comment. She said, like my mom always said, you don't have to agree with someone's feelings or fears, but that doesn't mean they don't have the right to feel like they do. Yes. And those are real to them, regardless of your perception and feelings. Absolutely. Well said. So your mother is a wise woman. So, but one of the things that it is hard, and I want to talk about when people are in crisis, they sometimes when they come into your setting, Monique, they haven't always given a release of information for family to talk, for you to talk about them to their family, or especially for the folks here, like if you've sent someone to a higher level of care, meaning they've gone to the emergency department, the patient or your client, when they get there, they may not give you permission, even though you sent them, they may not give you permission to know anything about them. And that happens. But I think one thing that's really important is you can still call these behavioral health emergency departments or an emergency department or wherever you've committed them to, if you've done an involuntary commitment, you can still call and give collateral information on the phone. And you were actually saying, Monique, yesterday, talk to me about the quality measures that you.
I think you're talking more about the just
getting collateral information.
Okay. Yes. So I think everyone should know as clinicians, it does not matter whether or not the person you're engaging with consents to you getting information from people in their family or whoever you have access to. I think gathering information is not, violating their HIPAA rights in any kind of way. Now, if you were to say they are here in a crisis or, that your treatment plan is A, B, and C, yes, that is violating that is violating HIPAA. But we can always gather that collateral information, and it is so important to do so. No, confidentiality, again, you're not, I'm sorry, I just saw the comment. Does it violate confidentiality? No, because you're not telling this person anything confidential about this person. You are gathering information about your client and your patient. And that is so important to do because a lot of times patients are not going to necessarily be honest with us. Even as comfortable as we may have made the environment be for them to come and talk to us, they still are going to be nervous about disclosing these things that are probably very concerning to them as individuals. So they may not want to talk about the fact that they've been having thoughts about wanting to kill themselves. They may be afraid of us judging them, for example. So again, getting collateral from families, what's their behavior been like? Have you been concerned about their mood or the way that they're interacting with each other? Has there been any kind of dysfunction in the way that they're attending school or their work functions? that sort of thing.
Mm-hmm. So they can't go deep into like, and what I think people are trying to understand is you can't go really deep into like things that you've talked about into psychotherapy or anything like that. But if someone is a danger to themselves or definitely a danger to others, then that does need to be communicated, and communicated really clearly. So they said, what if they don't want the person to know it's in the hospital? So that's a good question, right? You can't.
Let me go ahead.
Please.
So how do you start the conversation with families? If they are there on site, of course, they kind of know the situation. And we actually do have a form that we could give folks to fill out, parents, family members. It's called a collateral sheet where they can write down their concerns for the person. Let's say, though, for example, I'm having to reach out to a family or member or a friend of theirs. I introduce myself. Hi, I'm Monique Ornelas. I'm a psychiatric nurse practitioner with this hospital. I have some questions about so-and-so and was hoping that you had some time to answer those questions. Done. And then I ask them, so can you tell me, have you had any concerns about their behavior or their mood lately? Have you noticed any changes in the way that they're functioning at work or at home with their kids? Again, gathering that information. The person can say no, like, I don't want to talk to you. I don't think that this is not comfortable. Or they may ask you a question like, well, how do I know who you are? And you have to explain again, this is who I am. This is the agency that I'm with. I can't really give you any other details as to why I'm asking these questions. I'm just hopeful that you would do so for your loved one.
That's great. That is great. Well, and that kind of moves us on to our next topic about building rapport, because a lot of times when you're dealing with the patients and clients, it's not just them that you're building rapport with, right? It's also the families and their support systems that you're having to build that rapport with. And I think that addressing people by their name is really important, making sure that you're authentic in your interactions, being empathetic, and then just helping them and encouraging them and affirming their responses. So is really, really important. Now I'm being cognizant of time because we're kind of running behind, but this has been fantastic discussion. Monique, thank you so much. And everybody in the chat, been amazing as well. I want people to share, and please, Monique, feel free. I want you to talk about this in our audience as well, to talk about immediate coping skills, things that you can do now when somebody's in a crisis and they can do. Because I know we have some listed there. I put dance as far as self-expression, because I learned a TikTok dance during COVID. And sometimes when I'm really stressed out, I'll put that little song on and I'll do a TikTok dance, and everybody in the family thinks I'm crazy, but that helps me to relax and kind of calm down. There's calling a friend, journaling, dancing, breathing techniques are fantastic. Christy said grounding techniques. I love that. Distraction, like take a shower. I love a hot bath. Rebecca, walking barefoot on the grass. Exactly. See, so that there are a lot of different things. Sandy, who is our chief of marketing, she gave one yesterday, is practicing gratitude, to think about what we are thankful for, and to maybe list like the top 3 things that you are grateful for in your life, because it's really hard when you're thinking about what you're grateful for, what you're happy for, to be in a bad place. But that doesn't work for everyone, right? That doesn't work for everyone. Kim, I love it. And sucking on a warhead, something sour. I love that. Aromatherapy, love that. Preparing a new recipe. DBT, distress tolerance, spirituality mode, Legos. I love it. I love it. Great. Calling a trusted friend. 5 senses. I love that. Exercising, laying in quiet. looking at the stars. Cleaning works for you, Chelsea. That's amazing. That's amazing. Cleaning does the opposite for me, but I appreciate that cleaning works for you. That's awesome. Massage therapy. Oh, yes. Monique, you had shared something that I thought was really, really helpful. It was a tool yesterday that you talked about.
Sure. So part of our goal of someone coming into the emergency department, if we are looking more towards hopefully getting them back home and more towards outpatient resources, I have to engage them in an ability to cope with whatever that crisis that they are in. A lot of our folks are going to often have negative emotions, negative thoughts. Unfortunately, a lot of the clients, at least I see, have had ongoing or intermittent suicidal or thoughts of self-harm their whole lives or for many years. So going through a safety plan with them is so important. And first and foremost, typically, we always tell folks call 911 or 988 is our new our mental health crisis emergency line now that's nationally wide, which is fantastic. Oftentimes we ask them to reach out to their friends, their family, people that they can trust. However, when I'm speaking more one-on-one with someone in the emergency department, it's been my experience that them calling someone and asking for help is not necessarily going to be their first thing that they're going to want to do. I think oftentimes we want to not burden our friends or our family, or we're, a little worried about our friends and family knowing these negative things about the way that we're having that we're feeling. So I like to make sure that I can engage them in things that they can do for themselves whenever they're having these negative thoughts or negative feelings. And one of the main things I like to do is do kind of some guided imagery where we pick a very specific memory in which they were feeling a very happy or humorous feeling, however they describe it themselves, but they were feeling good in that memory. And I want them to tell me exactly, what they're sitting on, for example, or if they're standing on something, what does that structure feel like? Are you sitting on something plush or hard, plastic? What are the smells in the room? Is somebody cooking something? Is somebody burning a candle that smells like vanilla or a fir tree? Who is in that room with you? I want you to really imagine their faces. What types of expressions are those people making? And it's very helpful in getting them engaged in something that they can do that's very personal to them versus me telling them things like, yep, so when you're in a panic attack, look at that, look at something fixed on the wall and count to 10. That can be just very not personal for them. And I feel like when I give them that little bit more personal engagement, then we're able to get something that they're going to really be able to utilize when they're in a crisis.
Absolutely. Absolutely. This is great. And we've got a lot of great, Mary says, and if you haven't seen Mary's comment, please take a look at that. Creating a playlist for a negative room, for their negative room. I love that. Positive songs when they feel sad. That is just a great comment. If you want to check all that. Terry says, is the safety plan evidence-based practice? Listen, I think there's lots of studies out there. I think there need to continue to be more studies, but I do like that Natalie comes in and says, creating that safety plan is healing and empowering for the clients. And we're going to talk more about that. We've got a lot of things going on as far as music can be healing, but Nora brings out a good point. It can also be triggering. Nicole has an excellent comment as well as far as coming up with code words when they feel too overwhelmed. For example, frog. I think that's great, having a code word. Linda says adult coloring. I love an adult coloring book. I do. I'm sorry. I'll tell you that is one of the things that I absolutely love. So that is fantastic. Code words are great. I think we talked about a debriefing a little bit. We've kind of covered this, and because of time, I need to kind of move on. But we do want to talk about the safety and crisis planning and what that would include. Like, what are the warning signs? What are the triggers? Who is your social support? Healthy coping mechanisms, all of these things that, Monique, you've talked about and have been covered in the chat, and also information regarding emergency contacts and services. This is what the iConnect safety plan looks like. One of the wonderful parts of my job, and today is just an example of that, is I get to work with really amazing clinicians all around the United States, all around the world, really, who use the program. And so I worked with a lot of clinicians, and we came up with this safety plan. And so this is what our safety plan looks like. It is in the handout. Please, yes, go right up to the handout section and click on that, and that safety plan will be in there. And at the bottom of the safety plan, there is a list. So the bottom of the safety plan, there's an absolute list that you can go through that has all the numbers, and it's like domestic violence numbers, LGBTQ numbers. There are all kinds of different numbers in there that people can call, because Monique brought up a really good point. A lot of times people don't feel comfortable sharing these things with their families or friends. They don't want to burden people. So absolutely. Now I want to go in and we're running really short on time, so I want to go ahead and kind of wrap up a little bit. And please feel free to write down any questions you have for us. I don't know if we're going to have time to get to all the questions today, but I want to thank you so much for just being, for actively participating. I think we went over crisis and really wonderful ways to handle that. You do have the handout so you can refer to, but you also have a lot of peers and colleagues in here that gave a lot of excellent suggestions. Monique, thank you so much for your suggestions. I mean, really, really, I love that. And Christina brought up the Calm app. The Calm app, I think, is good. They've got virtual Hope Box app, Christina brought up. So yes, we're definitely, so a couple things that we're going to do. We are going on the handouts. You have a couple handouts up there. You should have the handout for the safety plan. There should be one about triggers, writing down triggers. There should be like a Wong Baker assessment handout plan up there. It's Wong Baker is copyrighted, of course, but we created our own little version of that for emotions. And so that is in there. And then we have a whole handout on crisis, but you will get that handout with all of those little things in there, safety plans, all of that. It's about a 20-page handout. And then you'll get that. You'll get the slides from the presentation, and you'll get a recording of the presentation so you can share with whoever you want. And Natalie said, would you consider making a safety plan for kids that incorporate coloring and a kid-friendly appearance? We can absolutely do that, Natalie. That would be my pleasure to make that. Absolutely. Now I am going to show you, and thank you guys so much for the webinar, or for your responses in the webinar, and thank you for your thank yous. I appreciate that. I am going to show you really quickly iConnect, because we are the host of the webinar. And I'm going to show you kind of what iConnect can do as far as your documentation, because getting through the crisis is difficult. It's very difficult, but then you have to document everything that happened. And I'll show you exactly how you can do this. So in iConnect, this is iConnect Plus. So if it looks a little bit different for classic users, that's what this is. But to create a progress note in iConnect, you just click on progress note. It'll literally take you through and document what the client has symptoms of. So I can go in and say, you know, they have symptoms of, and we can talk about depression, and that is present, and maybe it's chronic, and we can say that they have crying spells, and that is present, and they're fatigued, and that's actually worse today, and their sadness is worse, and maybe they're having some school misconduct, and that is definitely present. They're having feelings of worthlessness, and that's present. And then we can talk about if they're suicidal. And I think that's really important to include in all of your notes. Like if they're not suicidal, then we want to document that their denial is convincing, right? And then I can go through and talk a little bit about their behavior, like maybe on their self-care that's been really reduced, their functioning. Let's functioning at work could be marginal. If they're in school, we could talk about school functioning. We could talk about anger, impulses, and sleep. I could say that they've had sleep problems, falling asleep and staying asleep. And then we could definitely talk about like what you're doing with them or what their problems are. I could say that this was, we'll say that this is having problems with school, and they're having depression, and they're having low self-esteem. And then what are we going to do as far as our session goal? Maybe we're going to work on coping skills and their self-esteem, and then their interventions. And we'll talk about self-esteem enhancement. We also talk about giving them support and ventilating feelings. And then we can do a mental status exam. Now, one of the wonderful things about if the mental status exam, if it's normal, the system will populate a normal mental status exam and use the patient's name and their pronouns in there. And it uses he, she, they in there. And then we can also talk about, you can do your suicide violence risk assessment. You could talk about justifying level of care, because unfortunately we do have to advocate for patients and clients, especially in the outpatient setting, making sure that they continue to get the sessions that they need. So I could say it's interfering with their day-to-day function and it requires continued treatment. And then we do have EMDR notes. We do have play therapy notes. And then I can go in, I can also link in my treatment plan as well. So it looks like I have a beautiful note that I spent hours and hours and hours on, and I did not. So, and any of this you can type in this as well. And this is what your note will look like. So that's just a little demonstration of what ICAN Notes can do. Treatment plans are just as easy and effective. We have online scheduling with our calendar, and we have a billing as well within the system. So really do a lot with ICAN Notes. A lot of you are ICAN Notes customers, but some of you aren't. So I did want to show you this. And we do have the classic ICAN Notes program, but this is our new Plus program. So, and again, thank you so much. You guys have been absolutely fantastic. Thank you so much, Monique. Thank you so much, everyone that's in this webinar. I so appreciate you. I appreciate your comments. So thank you. Gracias. Thank you.
Thank you so much.
Thanks. Bye-bye.